Hi everyone, apologies for starting late. Thank you so much for joining us for this urological tutor. So today's tutor is on the common urological conditions and it's given to us by Devika. So just a few rules. If you're watching via Zoom, any questions or comments for things that are covered in the moment, if you just want to pop it into the chat. Any questions that can wait to the end, if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions or comments and we'll pass them on to the tutor. And that's all from me now, and I'll hand over to Devika. Thank you.
Thanks for that. Hi guys, so I'm Devika Verma. I'm a fifth year medical student at UCLan, and today we're going to be talking about common urological conditions. Like they said, just pop any questions you have either in the Q&A in the chats, and then if we have time, I'll try and stop in the middle so I can answer some of them. Right. So that's just a disclaimer from becoming a doctor. So the learning objectives for today is to gain a basic understanding of common urological conditions. We're going to go through some types of urological malignancies and also get an idea of some acute presentations you'd see in urology. So to get started, this slide is just sort of to give you an idea of how a patient typically would present. So for someone who has urinary tract stones, they are going to have pain. The hematuria is usually going to be microscopic, and it's unlikely for them to have any low urinary tract symptoms or incontinence, but they will have systemic symptoms, so nausea and vomiting, pyrexia, and coming to urinary tract infections, again, a bit similar to the stones, you will have pain. It's unlikely to have hematuria. They can have low urinary tract symptoms, but no incontinence, possibly some systemic symptoms. It depends on how unwell they are. BPH, so you won't experience any pain or hematuria, but you will have low urinary tract symptoms. Possibly you can have some urinary incontinence, and it's quite unlikely you probably won't see any systemic symptoms. Malignancies, so probably the three main ones you guys should know is bladder, kidney, and prostate. Starting with bladder, you typically don't have any pain. They'll have hematuria, which will usually be macroscopic, low urinary tract symptoms, no incontinence, but they can have systemic symptoms. So they can have bone pain, weight loss, things like that. Kidney cancer, again, they can experience pain, macroscopic hematuria, and systemic symptoms, but unlikely to have any urinary symptoms or incontinence. And prostate cancer is, again, known to the pain or hematuria, but they possibly will have low urinary tract symptoms and systemic symptoms. And the last one is sort of acute presentations. So in urology, you should know about urinary retention as acute problem and testicular pain. In urinary retention, they will be experiencing pain, but all the rest of the things are quite unlikely. It will depend on how sick they are and what other comorbidities they have. Testicular pain, it sort of gives it away. They will have pain, and they probably will have systemic symptoms, but it's unlikely to experience any of the other things. And this slide is more of a guide as to how someone would typically present. It's not set in stone that you will experience pain and you will, but this is like, in general, this is how you would see people. So if you guys read this question, and I will bring up the poll for you. So we'll give you a few more seconds to get some votes in. Right. Okay. So we stop it there for the moment. And I'm hoping you guys can see the poll results. So it's good the majority of you said calcium stones, and that is true. Calcium stones are the most common type. Uric acid and cysteine stones are quite a low percentage. After calcium stones, which account for 75%, struvite stones will be the next, which account for 15%. But I'll talk more about this in the next slide. So I did that. Yeah. So let's talk a bit about urinary tract stones. It's the commonest reason for someone to be admitted for an emergency urological reason. It's more common in males, and typically you'd see someone aged 20 to 50 years. The causes, well, there can be metabolic causes, so such as hyperparathyroidism, etc. Infections can precipitate it, impaired urinary drainage. Even so, even your lifestyle can have an effect on it. In terms of how it presents, someone will come in with severe intermittent stabbing pain, and that can possibly radiate from the loin to the groin. Hematuria, which will usually be microscopic. They can have renal angle tenderness, and you can see systemic features like nausea, vomiting, pyrexia, tachycardia. So coming to the types of stones, as you guys mentioned, calcium stones is the majority. So these can either be calcium oxalate or calcium phosphate. So if you hear someone say calcium oxalate or calcium phosphate, they all come under the umbrella term of calcium stones. So it is the most common. Struvite stones, the way I like to remember it is MAP. So M for magnesium, A for ammonia, and P for calcium phosphate. And these account for 15% of the stones. All the others are not as common. So I think if you know the first two, you'll be good. Investigations. So you would do your bloods. You're doing a full blood count to see if there's any infection going on, CRP for any inflammation. You also want to check the electrolytes and see how everything is, and creatinine to get an idea of the renal function to make sure it's all right. The gold standard for detecting stones is a non-contrast spiral CT. And we're doing a non-contrast because you can see the stones without contrast, and you might be able to see them more clearly. That's why we do non-contrast. Additionally, it depends on how the patient is. You can consider an X-ray and intravenous urogram or renal ultrasound. So management. It depends now if the person who comes to you is acutely unwell or if it's an elective presentation. So if they're acutely unwell, I have highlighted in blue for you the key things you need to do. So first, you want to give them analgesia. You want to give them an antiemetic. Depending on how sick they are, you might need to give them IV fluids. And then you either wait for the stone to pass naturally. So that would typically, if the stone is less than 0.5 centimeters, you'd allow it to pass naturally. Or if the patient is in pain or you suspect an obstruction, you would do a percutaneous nephrostomy plus minus a stent insertion. And that will depend on how the patient is. A percutaneous nephrostomy is basically you're going to be inserting a needle into someone's back where the kidney is to relieve the fluids and thereby relieving the pressure on the kidneys. And to detect if someone is in obstruction, that's when you'd possibly consider a renal ultrasound, which might show you some obstruction. Elective presentation, so you can consider extracorporeal shockwave lithotripsy, and there are a couple of other options, but it just depends on what the patient would prefer and how they are. So another important aspect to remember about stones is preventing them. And the key things to remember is you need to increase your oral intake, reduce calcium intake, and check for any metabolic abnormalities. If there's an infection, you want to treat it. And in the other section, I mentioned urinary alkalization and thiazide diuretics. Now, these are only for cysteine or uric acid stones, so these are pretty rare. So you should probably have an idea of the first four. That would be more useful. Right. So I'll give you guys about a minute. Have a look at the CT, and once you've detected what's wrong with it, how would you manage the patient? Okay, so I'll give you guys about 10 more seconds to put in your votes. So I think that's fine. Yeah, so now we're sharing the results. The majority of you said percutaneous nephrostomy, which is correct. Then you've given other options such as stenting, extracorporeal shockwave therapy. None of you put endoscopic and supportive management. So we don't have much information about this patient, but if we see the CT, we can clearly see that there is a stone. Oh, sorry, just give me a second. Yeah, so if you see the CT, you can see that there is a stone here in the left ureter, and you can see quite gross hydronephrosis. So just from the CT, you could possibly predict that the patient is unwell. Considering the patient is unwell, you would go for an emergency treatment of the stone, and that would be percutaneous nephrostomy. Stenting is not wrong, but the first thing you'd always do is the nephrostomy, and then you can consider whether or not you need to stent. So it's an add-on, but not the first thing. The first thing would be the nephrostomy. Shockwave therapy would be if you, for an elective procedure, the patient, it would be safe to assume that this is more of an emergency situation. And supportive management, while we don't know what size the stone is, if it was just a stone and there was no hydronephrosis, you could consider supportive management. But in this case, we are suspecting obstruction because of the hydronephrosis. So we would go for a nephrostomy as the first option. Right, I'm hoping that made sense. So now let's talk a bit about BPH. It's the commonest cause of lower urinary tract symptoms in middle-aged and elderly men. The cause is unknown. There are a few sort of factors that can affect it, but largely speaking, we just say it's unknown. Now, I've highlighted central and transitional zones, and as you guys would remember from anatomy, the prostate has 3 glandular zones, so central, transitional, and peripheral. And the central and transitional zones are the ones which are most prone to getting BPH. So I think that's quite an important fact to remember. Clinical features, storage and voiding symptoms. So a lot of times I've mentioned the term lower urinary tract symptoms, and that's basically an umbrella term for storage and voiding symptoms. So if you can see the 2 circles on the right-hand side, storage symptoms are basically, if you imagine your bladder as the store, which is storing the urine. So if there's a problem with it, you might experience urgency, you might experience frequency or incontinence, nocturia. So there's a problem with how it's storing it. Voiding symptoms is, so if the bladder is a store, the way it exits, the pathway it exits is sort of the voiding symptoms. So if you get hesitancy, poor stream, terminal dribbling, or abdominal straining, these are all voiding symptoms. And this is basically when someone says lower urinary tract symptoms, you divide it into storage and voiding symptoms. And then you have an idea of what goes on to each category. Additionally, if you do a digital rectal examination, you'd see quite a smooth and enlarged prostate, and the median sulcus would be well defined. I've said that you should always remember to examine for neurological conditions, neurological signs in those with lower urinary tract symptoms. So that's particularly important because we're thinking about one condition in particular. I don't have a question, but if you guys can pop down in the chats any idea what this condition might be, and then we can have a look. Yeah, so that's great. You guys said cauda equina. That's one of the main things we worry about. So you always want to check to see if they have any urinary incontinence or bowel incontinence, as well as the opposite. It could also be urinary retention. So you want to check all these things and make sure cauda equina is not there. Complications, there's a whole list of complications that are associated with BPH. And I think it would be worth it if you guys have a read in your own time. Yeah. So investigations, you do urine analysis. You want to check if there's any ongoing infection. You can do bloods, PSA, creatinine. Now, it's important to know that with PSA, you also consider it in case of a malignancy, but there are a whole host of reasons why the PSA can be raised. So for someone who has, if you've been recently sexually active, if you had an infection recently, any biopsy or any kind of surgery, so a lot of things can raise your PSA. It's just worth knowing that. Creatinine, we want to see if the renal function's all right. Digital rectal to see, as we previously defined, how the prostate is. And for someone who might need to go an intervention, you can consider urine flow volume and residual volume estimation. So basically, you just want to see how the bladder is working and whether the prostate, the enlarged prostate, is having an effect on it. There are other investigations you can consider, but the ones I mentioned previously are probably the first line, the ones you would do. Now, in terms of management, if the BPH is affecting the quality of life, you'd probably, or they have any complications, you'd probably go into managing them. We usually divide it into medical treatment and surgical. So in terms of medical, either you can just watchful waiting, so you can just do nothing, see how the BPH progresses. If it's not severe, some patients would just want to do nothing and wait. Otherwise, you can consider medications. So the two main categories are alpha adrenergic antagonists, and you should know the side effects, which is dizziness and postural hypertension. And the other one is 5-alpha reductase inhibitors. So that's an example would be finasteride. And side effects with this is loss of libido and erectile dysfunction. And quite commonly in GP, you would see patients come in with a 5-alpha reductase inhibitor complaining of erectile dysfunction. Surgical treatment. So for those who are unresponsive to medical treatments or again have complications, you go on for a surgical treatment. And the most common procedure is transurethral resection of the prostate. There are other procedures, but I think the one you should know is TURP. I've mentioned the other ones in the notes, so when you guys get the slides, you can have a look. So just another question for you guys. Which of the following is the most common long-term complication of TURP? I appreciate you may not know the answer, but it'd be worth just having a guess. So about 10 more seconds for this question. Yeah, So, yes, I'm hoping you guys can see the answers. So, about 33% of you said urethral strictures, and then it went to erectile dysfunction and retrograde ejaculation and incontinence. Well, the answer is actually retrograde ejaculation. So, if I stop this sharing it, one second. So retrograde ejaculation is actually one of the most common long-term complications. It's seen in about 80 to 90% of the patients. All the others are complications and some of them long-term, but they're not as common as the first one. So just to speak a bit about TERP, what happens is that this instrument, which is called a resectoscope, it passes down through the urethra all the way down to the penis to the prostate. And then they sort of, use, there's a loop which heats up and it destroys the extra tissue of the prostate. As you can see here, some tissue is destroyed. And then they pass the catheter in with fluid to remove these extra bits and bobs, and they remove the resectoscope. That's essentially what a TERP is. But it's important to know the risks associated with it. So retrograde ejaculation, one of the most common. Other things you can experience is temporary or permanent incontinence. Is usually temporary, lasts about 3 to 4 weeks, and then it gets okay. Urethral strictures account for about, I think, 5% of the complications. Erectile dysfunction is about the same. All the other ones are more rare complications of a TERP. An important one to know is TERP syndrome. It is quite rare, but it's something you should know. So what happens is that, once you've destroyed this tissue and you put a catheter in to put in fluid to remove these bits and bobs, you put in too much fluid, and that too much fluid gets absorbed into your body. And because of that, the patient then can feel really unwell. So they can get short of breath, they can get cynosed, they can feel sick. So you just get acutely unwell patients. So it's worth reading a bit more about it. Right. We're going to talk a bit more about malignancies. We're running on time, so if you guys have any questions till this point, if you can just either pop them in the chat box. I'll give you a couple of minutes for that. If not, we'll move forward. Okay, so I haven't got any questions now, but after we can complete the malignancy section, oh wait, I think there's one. What are the most important drugs used to treat UTIs in general? So the most important drugs, you would use antibiotics, and that would either be nitrofurantoin or trimethoprim. Yeah. I hope that answers your question. I'll type out the answer later as well, so you have the drug names. Yeah, as I was saying, we'll complete this next section about malignancies. And then again, I'll give you guys a minute if you have any questions. So if you... Right. So the next one, we're talking about malignancies. Which is the most common type of bladder cancer? Just gonna open the poll for you guys. Okay, so the majority of you answered transitional cell carcinoma, and that is correct. That is the most common type of bladder cancer there is. So bladder cancers, TCCs account for approximately 90% of bladder cancers. They are more common in males. Risk factors are quite important. So smoking, especially in women, and occupation. So any occupation associated with the rubber industry, dyes, petrochemicals, and chimney sweeps. Schistosomiasis is also a risk factor, but only for squamous cell carcinoma. Clinical presentation. So the majority of people will just present with painless hematuria. Additionally, they can't have low urinary tract symptoms. They can also have recurrent UTIs. So if you do see someone who's presenting with UTIs every 1 month or 2 months, you might want to see if something else is going on. The gold standard for investigating bladder cancer is cystoscopy with biopsy. Additionally, you can consider a urine dip or cytology. So again, you're checking for infection and you want to see if there's any malignant cells. You can do an IVU or ultrasound, and that's if you're suspecting any involvement of the kidneys, any obstruction. You can do a bimanual, an MRI or CT. You probably might need the MRI or CT later for staging, but the initial thing would be the cystoscopy with biopsy. So in terms of staging, I am sure you've all heard of TNM staging. So this is the one for the bladder. You have, as you can see, the first one is CIS, and that just means that you have high-grade cancer cells, but in the innermost layer of the bladder lining. So it's called either carcinoma in situ, CIS. Sometimes they can even call it TIS, but it's the same thing. Then you can just skip the T1, which means that the cancer has started growing into the connective tissue. And T2 means that now it's invading the muscle layers. So this will be divided into A and B. So A will be superficial, B will be deeper. T3 means it's invading the fatty layer, and T4 means it has now crossed the bladder and it's invading the outside structures. And then as TNM staging, this is the T part. You'll have one for the lymph nodes and one for any mets. So management will depend on your staging. Usually the 70% of bladder cancers are superficial in nature, so it makes the management much better. You would do an endoscopic resection and surveillance. The surveillance bit is quite important because bladder cancers have a high chance of recurrence, so you need to keep on surveilling them. And additionally, you can consider intravesical chemotherapy. If it's an invasive bladder cancer, or you have another form of bladder cancer, such as SCC or adenocarcinoma, you should just remember you go for a radical cystectomy. That's usually the first choice. And additionally, for if it's a transitional cell, you can do radiotherapy, but the other types are quite resistant to radio and chemotherapy. So surgery would be your mainstay of options. Okay. Next, we're going to talk a bit about kidney cancer, and adenocarcinoma is the most common one. So this accounts for about 2% of all cancers, again, more common in males. Risk factors: smoking, obesity, if you have a positive family history of cancer, and von Hippel-Lindau disease. On the right, you can see I've made sort of a triangle, and this is a classical triad you would see in kidney cancer. So someone with painless hematuria, who may have loin and groin pain along with the loin mass. And this classical presentation is seen in about 50% of the patients. The other 50% might just present with either one of these or two of these, and they may have other systemic features. So your clinical presentation is this triad, but then additionally, you may have systemic features like anorexia, anemia, chest symptoms, so shortness of breath secondary to cannonball meds or bone pain. I've underlined the shortness of breath secondary to cannonball meds because this is quite a favorite one in exams. So kidney cancers commonly can spread to the lungs, metastasize to the lungs, and that's what's going to cause your shortness of breath. Locally, they can spread into the IVC and renal vein. Investigation. So the gold standard would be a pre and post IV contrast enhanced CT. You can do bloods. Again, you want to get a baseline value, see if there's anything else going on. ALP particularly because you want to see also if the calcium, and if you want to see if there's a correlation with the bone pain. Isotope bone scan, again checking for any mets, and ultrasound the IVU. You cannot consider, it'll depend. Management. So the only curative treatment option for kidney cancer is surgery, and you can do a radical or partial nephrectomy. That is going to depend on how extensive the cancer has spread. If you're considering medical therapy, it's usually because it's a metastatic disease. So the options are biological therapy, radiotherapy, hormonal therapy. But what's important to remember is that kidney cancers are not usually chemosensitive, so they won't respond well to chemotherapy. So that's one thing to not offer. Right. Coming down to prostate cancer, I am going to open the poll for you. But the question is, which glandular zone is most prone to prostate cancer? And so I'll give you guys about 5 more seconds to put in your votes. Okay, so good job, guys. The majority of you put down peripheral, and that is correct. Peripheral is the zone most prone to prostate cancer. The other zones, central and transitional, are the ones that are more prone to BPH. Okay. So again, prostate cancer, the most common one you're going to see is adenocarcinomas. It's the most commonly diagnosed cancer in males in the Western world. Usually the peak incidence is the 8th decade and the peripheral zone of the prostate. Clinical features, they usually present with low urinary tract symptoms, but you can see other systemic things such as weight loss, fatigue, bone pain, that's quite common to see, and pathological fractures. On examination, if you do a digital rectal, you would see a hard, irregular prostate, and you won't be able to feel the median sulcus. Now, if you do remember in BPH, this is the opposite, where it'll be quite a well-defined medial sulcus, and the prostate will be nice and enlarged. Investigations. So again, bloods, PSAs, usanies, ALPs. You want to, then the two main things to consider is a transrectal ultrasound with biopsy and the multiparametric MRI. And that's both to just get an idea of where exactly the cancer is located, how much has it metastasized. And sorry, this should say isotope bone scan. And that's again, you're checking for any mets if this spreads. In terms of the staging, again, there's something known as a Gleason grade, which you guys can read about in your own time. It might be worth having a little bit of an idea. And the other thing is a TNM score. So TNM score, like you all would know. So T1 is if it's in a very small proportion on one side. T2 is the same, but it's vastly spread. T3 is it's invading up to the fatty layers, but it hasn't spread outside. And as you can see, T4, here we have the cancer that's growing out into the other structures. So management. So you have quite a few management options you can explore, and one of them is active monitoring. And that's one where you don't give any treatment and you would just continuously monitor them every 6 months to a year, you'd monitor the PSA, you might do a scan and see how it's progressing. The other options you can consider are radical prostatectomy, external beam radiotherapy or brachytherapy, and hormonal treatment. Now, external beam radiotherapy is quite useful, especially if you have any bony mets. It really does help with the bone pain. Brachytherapy is it's a form of radiotherapy where they're going to insert tiny radiologically active objects into the prostate, and then they're going to stay in the prostate and do their work. Hormonal therapy is also hormonal treatment is also one that's commonly used. If you do consider a radical prostatectomy, you need to know the complications, and those erectile dysfunction is quite common, seen in about 40 to 50%. And the other one is incontinence. Right. So that covers malignancies. Again, I'm going to give you guys a couple more minutes. If you have any questions, just pop them down either in the chat or in the Q&A session, Q&A folder. Okay, so the last thing we're going to be talking about is acute presentations in urology. And so the first thing we want to talk about is acute urinary retention. And my mistake. Okay. So acute urinary retention causes can either be general or local. By general, I mean if someone's had surgery, if they're on any particular kinds of medications, such as anticholinergics, or if they have any neurological problems, or particularly any spinal disease, they can get acute urinary retention. But I've emphasized a bit more on the local causes, and that can be prostatic enlargement, someone either with BPH or cancer, if there's a stone impacted, pressure on the bladder, so fecal impaction, UTIs, and infections in general, actually, and post-urological surgery. There are a whole host of things that can cause acute urinary retention. On examination, you'd see a patient who would have suprapubic pain, they haven't passed urine, and when you palpate, you'll be able to feel the bladder, and when you percuss, you'll be able to hear it as well. In some cases, you might see prostatic enlargement, and that could either be because of the enlarged prostate you're having retention, or it could also be an incidental finding. So in terms of managing, the three main things to do is first resuscitate the patient. So you want to make sure that they're as comfortable and they are stable enough to investigate further. Once they are that way, then you want to establish a diagnosis. So that would include your other examinations, histories, investigations further. And once you know what it is, you're going to want to treat it. But a few key things to focus on is resus. You want to first give them analgesia and a warm bath. So warm bath is more probably applicable if they have chronic retention. It does help to sort of relax the bladder and help pre-void. The other thing you want to do is catheterize. And what's important is that you document the initial amount of urine that has come out through the catheter. Once you do get the urine, you want to send it out for a microscopy, culture, and thing. And that's just because you want to see if there's any infection brewing. If not, if there are any malignant cells. And you also want to do some bloods to get a baseline idea of how the patient is. So full blood counts, you're again checking for any infection, use any electrolyte abnormalities, and creatinine because, well, if you are in acute urinary retention, you want to make sure that the kidney function is preserved. So once you've resuscitated them, you've got some basic things in. To establish a diagnosis, you want to first take a full history. You want to do a full examination, especially the neuro, as you guys mentioned earlier. Check the medications, because certain medications can precipitate retention. And once all that is done, you want to treat them. When you're treating them, whatever the condition may be, you want to make sure you continue to monitor the renal function and the fluid balance, because you don't want the kidneys to either be damaged or them to go into retention again. So acute urinary retention is more sort of a symptom, and you want to treat the cause, and the cause could be anything. So you need to figure out what it is. The other thing to think about is acute testicular pain. So when someone comes in with acute testicular pain, there are a few conditions that should just hit your head. So one of them is torsion of the testicles. The other one is acute epididymal orchitis. And there are a few others I mentioned under other. They're not as common, but if you just know that they exist, that would be good. So I'm just going to talk about torsion of the testicle and acute epididymal orchitis. So torsion is an emergency. You usually see it in someone who's between 12 to 18 years old. They're going to present with sudden onset of moderate to severe pain that's constant and is on one side of the scrotum, so unilateral scrotal pain. You're going to see nausea and vomiting, abdominal pain. Well, when you do take a history either from the child or the teenager or from the parent, you might notice that they would say, oh yes, my son has been having a few episodes over the last week where some pain comes, it stays, and then it goes away. So that's quite important to know, because that would point you towards torsion more. On examination, the testes, they can be tender, they can be enlarged, but the most reliable sign is this one: absence of ipsilateral cremasteric reflex. And usually that's along with the clinical presentation. If there is an absence of the reflex, you're going to straight away send the patient off to surgery. So the management is surgical exploration. Either you're going to fix it or you're going to excise it. It depends on if the torsion was detected early enough, and if the testes is viable, you want to fix it. If not, then unfortunately you might have to go for an excision. But what's important to remember is that both testicles must be explored in order to prevent further torsion. So if someone's coming with right-sided scrotal pain and it's a right torsion, in surgery you have to even explore the left to make sure you can prevent any further torsion. Next, we're going to talk a bit about acute epididymal orchitis. So peak incidence is about 35 years and above 55 years. Chlamydia and Neisseria gonorrhea are commonly the ones you see when they're 35 or lower. And usually when they get above 35, E. coli becomes the common one. What's good to know is that about 1/3 of the adolescent males who have had mumps can go on to develop orchitis. So it's a risk factor. Clinical presentation. So you have pain that is gradually increasing. It can increase over hours, it can increase over days. Along with it, you might see dysuria or urethral discharge. So as you can see, the causative organisms might be chlamydia and Neisseria. So you can suspect an STI. And if you are, associated symptoms would be dysuria and discharge. Along with that, they can have a fever. The cremasteric reflex is preserved, unlike torsion. And you might also see Prenn sign. And that's basically elevation of the scrotum sort of relieves the pain. So that's Prenn sign. Management, you want to give them medications, antibiotics, NSAIDs, like scrotal elevation, local ice therapy. And if there is an abscess, you would drain it. You may do an orchidectomy, but again, that's very rare. If it's a viral cause for the orchitis, your treatment is symptomatic. So apart from antibiotics on this list, you'd probably go through the rest of them. So in general, for acute testicular pain, so resus first, give them analgesia, make them comfortable, assess if surgical exploration is required. If it's not required, then consider a whole host of other investigations. So you can do an ultrasound, MSU, swabs, chlamydia serology. You want to see what's going on. And once you've done that, you establish your diagnosis and treat them accordingly. Right. So again, I'm going to give you guys a minute to ask me any questions you have about acute presentations. And then after that, we're going to go on to a few questions. Okay, that's fine. So let's start with this question. Mr. Brown is a 65-year-old male, and he presents with a 1-month history of painless hematuria, shortness of breath. He smokes 10 cigarettes per day for the last 20 years. Which investigation is most useful in establishing a diagnosis? I'm just going to open the poll for you guys. Right, so I'm going to give you guys 5 more seconds for any more votes. Okay. So the majority of you said flexible cystoscopy and biopsy. And I think we got about a vote for contrast CT scan. So the actual answer is contrast CT scan. But let's discuss this further. So I understand why you guys would have thought of flexible cystoscopy and biopsy, because you're thinking someone with painless hematuria and smoking is a risk factor, so bladder cancer. Yes, that's true, but they've also presented with shortness of breath. And while, yes, you can get shortness of breath with bladder cancer, it's not as common as it would be with kidney cancer. So smoking is a risk factor for kidney cancer. Shortness of breath could indicate that the cancer has metastasized to the lungs. Painless hematuria, again, is a symptom that you would see in kidney cancer. So probably the first step would be a contrast CT scan to see whether or not there's a cancer in the kidneys. If, of course, you didn't find one and you still suspect, then the next step would be to do a cystoscopy. I'm hoping that's clear, but we will take questions in the end. So if you have any questions, we can come back to them. Right. The next question is, Mrs. Singh is a 38-year-old female who presents with a 6-hour history of stabbing pain on the right side of her back. The pain is constant. The patient is unable to sit still. She complains of a heart racing, and she has started experiencing chills over the last hour. What is the first step in managing Mrs. Singh? All right, so I'll give you guys 10 more minutes to answer. 10 more seconds to answer. Right, so the majority of you said perform an A2A assessment, which is correct. That is the first thing you want to do. Performing an apto exam, well, that would kind of come under A to E. When you're doing everything else in the E part, you can do an apto exam. Okay, non-contrast CTKUB, I understand why someone said that. And that's probably what you would do after an A2E assessment if you're suspecting a stone. But the first thing you would do if a patient comes in and they seem acutely unwell, you want to do an A2E assessment, make sure they're stabilized enough, treat any other serious problems they might have before you go on to getting a diagnosis. So then we come on to the next question, which is still about Mrs. Singh. So she goes on to have a CTKUB, which confirms the diagnosis of a stone that's 0.5 centimeters in size in the right ureter. Her new score is, she's 110 beats per minute, her respiratory rate is 20, her oxygen sats are 98, temperature is 39, blood pressure is 130/80. What is the next step in managing Mrs. Singh? Right, so I'll give you guys about 10 more seconds to get the votes in. Okay, so the majority of you said sepsis 6, and that is correct. That's what you want to do. And watchful waiting, I've got one, so let's just work through all the options. So you can see that Mrs. Singh, well, she has a diagnosis of a stone. You can see that she's acutely unwell. She's tachycardic, she's pyrexial, and possibly tachypnic as well. So and earlier when we saw her presentation, she has started experiencing chills. So the first thing you want to think of is this sepsis. Do I need to rule it out? So you would start with sepsis 6. Additionally, your blood cultures would come under sepsis 6. You can do urine MCNS further. Watchful waiting, you might consider that for the stone if the patient wasn't unwell and she was just in pain. But since she is unwell, you might want to do the sepsis 6 and then additionally form another plan for her stone. So if you guys just pop in the chat box what the 6 components of sepsis 6 are. Okay, so that's good. We've got blood cultures, we've got fluids, antibiotics. Yeah, perfect. Okay, so that's good. So 3 in, 3 out. So you're gonna give high flow oxygen, you're gonna do blood cultures, antibiotics, a fluid challenge, measure the lactate and urine output. Blood gas is not really in it, but yes, if the patient is acutely unwell and it's appropriate, you can consider it. Right. Okay, guys. So that is the end of today's presentation. I would say continue to revise common urological conditions, have knowledge about managing a patient that's acutely unwell, in particular if it's a urological presentation. And this is not an exhaustive list of urological conditions. So make sure you read a bit more around the area. I have got a question from the chat box saying, would you still give fluids if the patient's on hypotensive? So in this patient, you may not need to give fluids, but it's also important to remember that when a patient is young, so Mrs. Singh is 38, their body compensates quite well. So they may actually be more unwell than their body is showing. So you might just give them an initial fluid challenge of 500 mils and see if they're doing all right. And if they are, you might just give it once. Okay, so that's the end of the lecture. I would really appreciate if you guys fill in this feedback form. You can either scan it or post the link. If you have any questions, I'm here for a few more minutes. I'll be happy to answer them. And thank you very much for attending. You guys had a really good lecture. That's good to hear.